The spirit of this Basaveshwara Vachana reflects the philosophy and mission of the life of Jagadguru Shri Shivarathri Rajendra Mahaswamiji, the 23rd Pontiff of Suttur Veera Simhasana Mutt, founded more than 1,000 years ago. Following the distinct lineage, Shri Shivarathri Rajendra Mahaswamiji blended spirituality with social reformation for the upliftment of the rural poor, marginalized and deprived people, establishing the formidable JSS Mahavidyapita. In 1928, when he was barely 12 years old, he was consecrated into the lineage by the 22nd Pontiff, Sri Shivarathri Mahaswamiji, popularly known as Mantra Maharshi, who had already established a Samskrita Patashala. Even as an adolescent student in Mysore, Sri Shivarathri Rajendra Mahaswamiji was deeply perturbed at the socio-economic disparities of the period, which deprived youngsters of food, shelter, and education. In 1942, he established a hostel and offered free food and hostel facilities for poor rural students who wanted to pursue education. This marked Sri Mutt's first step in the field of social development. With an aim of reaching education to all, he started the Jagadguru Sri Shivarathri Mahavidyapita in 1954. Thus began a silent revolution of Anna, food, Arivu, knowledge, and Arogya, health, which became the guiding principles of comprehensive development of a society inspired by the Sharana philosophy of Dasoha and Kayaka. What started off as a small hostel in the 40s evolved into an educational empire, transforming the dreams of several thousands of brilliant minds. The span of educational institutions he envisaged covers from Bala Jagat and primary and higher education, medicine, pharmacy, management, law, humanities, basic science, vocational and industrial training. Health of the poor was as important to Rajendra Mahaswamiji as education. Therefore, he laid emphasis in providing quality treatment and care at affordable cost to the poor through its hospitals. A humble primary healthcare center has grown into a huge 1,800-bedded hospital with state-of-the-art technology, experienced specialists, and empathy with care for the benefit of all strata of society. Shivarathri Rajendra Mahaswamiji firmly believed in holistic development of society and laid the foundation for many literary and cultural activities like Akhila Bharata Sharana Sahitya Parishad and its publication unit to spread the Sharana philosophy, Sri Shivarathri Jayanti celebrations, Shivarathri Dharmika Datti, music festivals through JSS Sangeeta Sabha, mass marriages and other activities that would contribute to the overall transformation of society. The legacy of Sri Suttur Mutt, the JSS Mahavidyapita, JSS University and many other offshoots of the great beginning continue to touch the lives of millions under the dynamic and spiritual leadership of His Holiness Jagadguru Sri Shivarathri Rajendra Mahaswamiji, the 24th Pontiff of the Mutt. Today, the JSS Mahavidyapita is a role model of social reformation through education. Its influence on the thousands of students stands testimony to the vision of Sri Rajendra Mahaswamiji. His empathy and care for the poor and needy is unparalleled. As we celebrate his birth centenary, we are ever grateful to his inspiration that continues to guide us. It is so true that he was neither born into the lineage nor was he groomed, but was ordained when Pattara Shivarathri Mahaswamigulu intuitively recognized that the child in the womb of Maramanni will succeed him. A society grows great when visionaries plant trees whose shade they know they shall never sit in.
I now request the respected principal of JSS Medical College, Dr. H. Basan Gadapa, to please welcome one and all present and also to give the introduction.
Good afternoon to all of you. At the outset, I submit my sincere pranams to the lotus feet of His Holiness Jagadguru, Shivarathri Rajendra Mahaswamiji, the Kayaka Tapasvi, on whose 105th Jayanti celebrations we are conducting. And I submit my sincere pranams to the lotus feet of present Chancellor, Jagadguru Sri Shivarathri Rajendra Mahaswamiji. It is indeed a pleasure for me to stand before all of you to welcome all of you for this wonderful program. Okay. As we mentioned, we are here today for two reasons. One is annual oration to be delivered by eminent academician Dr. Randeep Guleria and Teachers' Day celebration, because today on this occasion we are here to remember visionary His Holiness Jagadguru Sri Shivarathri Rajendra Mahaswamiji, who always stated, ignorance is the root of all evils in the society, and education is the only sound remedy, with which vision he established several educational institutions. I submit my pranams to Chancellor of JSS Academy of Higher Education and Research, Sri Shivarathri Rajendra Mahaswamiji, whose dynamic spiritual vision is taking us to the greater heights. Friends, we are here today to listen to the oration by a very eminent academician, Dr. Randeep Guleria. He was the first DM qualified pulmonary and critical care medicine person in the country, and his Padma Shri awardee. He is currently Director of All India Institute of Medical Science, New Delhi. He will be formally introduced by chairperson a little later. It gives me pleasure in welcoming the chairpersons for today. Two eminent personalities are chairing this session. Dr. B. Suresh, our founder Vice Chancellor of JSS University, which was founded in 2008, and is current Pro-Chancellor of the JSS Academy of Higher Education and Research. His dynamic vision and leadership quality has taken this academy to the greater heights, where we have been consistently ranked among the top 50 universities in this country for the last 4 years. Currently, we have been ranked 33rd. And all the institutions are ranked higher under his visionary leadership. I welcome our Pro-Chancellor, Dr. B. Suresh. Yet another person, Dr. K.S. Satish. He is a chief consultant pulmonologist, HIV medicine person, working in Fortis and Vikram Hospital, a very renowned academician, a prolific orator, a good friend of mine. He was my class fellow in MBBS days. Very simple, sober, very well behaved. Welcome you, Dr. Satish. I have a great pleasure in welcoming our Executive Secretary of JSS Mahavidyapita, C.G. Betsurmat, our Secretary S.P. Manjunath, our Vice Chancellor, Dr. Surendra Singh Ji, our Registrar, Dr. Manjunath, our Director of Academics, Dr. P.A. Kushalappa, our Director of the Hospital, Dr. M. Colonel Dayananda, Dr. M. Guruswamy, our Medical Superintendent, our two Vice Principals, Administrative Officer, Chairman of the Academic Society and Secretary of Academic Society. I welcome all those teachers who are here today, all those who are logged in, all those who are physically present in this auditorium. Welcome all of you. I welcome all those who have logged in from various places. The spiritual legacy of Sattur Mutt is more than 1,000-year-old. And the current pontiff is Jagadguru Sri Shivarathri Rajendra Mahaswamiji, who is following the footsteps of strong foundation laid by Rajendra Mahaswamiji for Mahavidyapita. Rajendra Mahaswamiji was a leading in front both in spiritual and educational drive. He was the 23rd pontiff of the 1,000 or more than 1,000-year-old spiritual organization. Born in 1916, at the tender age of 12 years, he took the baton to run the spiritual organization in Mahavidyapita. The wisdom, blessings, legacy impact of his predecessors culminated on him to produce what all has happened today. Every step he took was a step forward in search of new areas of service. He served the society tirelessly with selfless motive. Recognizing his services, German services, the honorary doctorate was awarded by the University of Mysore. His Holiness started JSS Mahavidyapita in 1954. With that, he went on to establish pre-hostels by the aim of giving Annadasoha, established universities and institutes to give knowledge, Gnanadasoha, established the hospital to give Aragyadasoha. That led to all-round development of the society in this state. JSS Medical College is one of those institutions which he dreamt and established in 1984, and the hospital was established in 1986. These were the 4 statements made by His Swami Holiness, which has taken his stature and our organization to the greater heights. He always mentioned, if you intend to do good work, do it right away. Don't wait for tomorrow. You don't know whether you will be alive tomorrow. All the patients are our affectionate relatives. Rogigalella nama bandhugulu was his statement. Work is worship was the great principle laid by great philosopher, social reformer, Sri Basaveshwara. And in verbatim, our Rajendra Swamiji proved it and did work is worship as his main goal. And he always stated, illiteracy is the root of all evils in the society, and education is the only sovereign remedy. That's how he established all these institutions and educating millions of people across the state. These are some of the pictures where Gyani Jewel Singh was the President of India who came to lay the foundation stone for our medical college. This is the current Holiness, Jagadguru Deshikendra Mahaswamiji, who is doing an earth-breaking ceremony on that occasion. And our visionary leader, spiritual leader, Dr. Rajendra Swamiji, was affectionately meeting with all the great leaders of the country and the state. This is the first student who took the application for medical college admission. This is the spiritual leaders and then his associates who were there. This was the first governing council meeting which was conducted for medical college. With that, we are here in this beautiful hospital, which is 1,800 bed hospital. I thank all of you for joining, and we are looking forward for a great oration to be delivered by Randeep Guleria. Before we request chairpersons to introduce the orator and give the citation, my request now is to request Swamiji, His Holiness Swamiji, to give the blessings to the participating audience. Thank you all.
అఖండ మండలాకారం వ్యాప్తమైన చరాచరం తత్పదం దర్శితమైన తస్మై శ్రీ గురవే నమః. Dr. Randeep Guleria, Director, All India Institute of Medical Sciences, New Delhi. Dr. B. Suresh, Dr. Surinder Singh, Dr. Colonel Dayanand, Dr. K.S. Satish, Dr. B.G. Basavanagodappa, participants and invitees of this auspicious event. We are happy to participate in the annual Oration and Teachers' Day celebrations organized as part of 1005th Jayanti celebrations of Jagadguru, Dr. Shivarathri Rajendra Mahaswamiji. It is in fitness of things that JSS AHER is organizing the Teachers' Day in a commendable way by including an oration by Dr. Randeep Guleria to invoke the memories of His Holiness Swamiji and Dr. S. Radhakrishnan. By doing this, JSS AHER is fulfilling its bounden responsibilities to the society by engaging in human service, which was the earnest dream of His Holiness Swamiji. His intense affection towards the poor and the afflicted resulted in the establishment of the medical college and the hospital, which serving thousands of people today. Today, we also remember the co-creators of the future generation, the teachers. The event is not only a fitting tribute to His Holiness Swamiji, but also to Dr. S. Radhakrishnan, a teacher, statesman, philosopher, and a politician. Any amount of discussions and interactions are not sufficed as far as COVID pandemic is concerned. The world is head-on collision with unprecedented and unheard of malady, where none has been able to comprehend it in its entirety. This oration on the issues and challenges in managing COVID-19 pandemic is sincere effort to find ways and means to find solutions. Dr. Randeep Guleria, as the head of AIIMS, is not new to Indians. In many of his TV talks, he has succeeded in boosting the confidence of the people in fighting the dreaded disease. JSS AHER and its team needs to be congratulated for having made this event possible. Many of the participants here are teachers. On this occasion, they deserve to be congratulated for their silent and faithful service to the society. We wish them success in their profession. We wish this event all the success. Om Tat Sat.
We sincerely submit our pranams to the lotus feet of His Holiness Jagadguru Deshikendra Swamiji, who blessed us today. Thank you so much, Swamiji. Now I request Dr. Satish, one of the chairperson, to introduce the orator, and that will be followed by reading of citation by our Pro-Chancellor, Dr. B. Suresh, who will be reading the citation and awarding the oration, and a gold medal will be worn by our Randeep Guleria when he is giving oration. Over to Dr. K.S. Satish.
Good evening, everyone here, and His Holiness Sri Swamiji, and my dear friends who are all participating on the occasion of Teachers' Day. I am very happy to be part of this Teachers' Day celebration, remembering all my teachers who made me what I am today. All my friends out there who are on the stage, who are participating, and who are part of this program, I thank you very much for inviting me for this wonderful webinar. To introduce the chief guest, who is a very dear friend of mine. We keep meeting in many CMEs. We travel together many a time. We traveled abroad, few months ago before the corona. And as already been said, Dr. Randeep Guleria is the director of the prestigious All India Institute of Medical Science in New Delhi. He is one of the first DM in pulmonary medicine in this country. Several awards were bestowed on him, honors came by, and the prestigious Padma Shri was awarded to him in 2015. He was also awarded aptly Dr. B.C. Roy Award for Eminent Medical Person in 2014. Himachal Gaurav Purashkar in 2011 and LIC ZTV. Swasthya Bharat Sanman in 2010 and recently Times Healthcare Achievers Award in the Legends category. Director of the Decade Award by the Indian Medical Association and National Excellence by the T.P. Junjunwala Foundation in 2017 and 2018. Dr. Guleria has delivered more than 8 prestigious national and international orations, has more than 450 publications to his credit, 49 chapters that he has contributed, and 50 research grants that is awarded to him, and more than 300 invited lectures that he has delivered. He is a personal physician to the Prime Minister of India from 1998 to 2004, a personal physician of many national and international dignitaries. He is also advisor and consultant to various international and national bodies, including WHO Geneva and IAFE Vienna. With all this credit that he has, he remains to be very simple, very humble, and he is available to anyone, and including, even though he is so busy with the coronavirus administration and also as the director of the prestigious All India Institute of Medical Science, his patient still, come to him, and he still manages his outpatient and some inpatient facility. Very humble and a very simple man, Dr. Randeep Guleria. Thank you.
Thank you, Dr. Satish, for a nice introduction. May I now request Professor B. Suresh, our Pro-Chancellor, to read the citation, award the oration to Dr. Randeep Guleria.
My respectful pranams to the lotus feet of His Holiness Jagadguru Sri Shivarathri Rajendra Mahaswamiji. I invoke the blessings of Jagadguru Sri Shivarathri Rajendra Mahaswamiji, whose 105th Jayanti celebrations was just celebrated recently on 29th August 2020. In fact, the participation in these celebrations took place with the dignitaries from across the world and globe participating and remembering the wonderful work done by Jagadguru Sri Shivarathri Rajendra Mahaswamiji. The Honorable Defense Minister of India inaugurated the program in the morning. There were the Prime Minister, the Chief Minister, then the different dignitaries from Karnataka participated in that meeting. And later on in the evening, the Lieutenant Governor of Jammu and Kashmir, Sri Manoj Sinha also participated and remembered the good work done by Rajendra Mahaswamiji. I would like to congratulate JSS Medical College for organizing the 105th Jayanti celebrations of the Swamiji in a very, very unique manner, in the manner in where the Swamiji's work is sort of, we seek his blessings on his all his efforts he has put us and the legacy which we are enjoying. At the same time, to get a very eminent personality to come and speak to the community of teachers, fraternity of doctors, and inspire many more people across the world through the digital medium, and be able to communicate to the world his thoughts and views, not only on medical science, which he would be sharing, but also the inspiration and courage and the positivity is going to share to them on the occasion of the Jayanti celebrations, the Teachers' Day, and also to deliver the 105th Swamiji's Jayanti celebrations occasion, to deliver the Rajendra Mahaswamiji Oration lecture also. JSS Academy of Higher Education and Research and JSS Medical College is indeed honored and privileged to give this citation to Dr. Randeep Guleria for his significant contribution to the field of medical education and pulmonology and sleep disorders. Dr. Guleria, as already explained by Dr. Satish, is a Padma Shri awardee. He is an alumnus of PGI Chandigarh, and he started his career as a professional career at All India Institute of Medical Sciences, and progressed to head the Department of Pulmonology and Sleep Disorders. And today he is the director of the same institute where he has been starting his career with. He has received several awards, and to mention specifically, the Rajnanda Pulmonary Disease Fellowship awarded jointly by Rajnanda Trust and the Royal Colleges of Physicians, UK, and the publications, the research articles, and the peer-reviewed opinions which has been shared in many platforms as won him laurels and accolades. And these are culminated in the award of the prestigious Dr. B.C. Roy Award, and also the Doctor of the Decade Award, as was mentioned by Dr. Satish. Dr. Randeep Guleria ji is presently the Director of All India Institute of Medical Science since March 2017. He is the chair and member of many various prestigious national and international bodies concerning healthcare. In fact, I have had the honor of meeting Dr. Guleria at various meetings at Nirman Bhavan when we used to participate for discussions on the various healthcare issues that were addressing the which were being addressed by the government. It has been my pleasure to interact with him at such meetings, though very briefly, and we look forward to the relationship which is going to be further nurtured through this meeting here. Dr. Guleria has a unique position in WHO and the Oversight Committee of Medical Council of India, and he is also a consultant to the International Atomic Energy Agency, Vienna, on radiation protection in medicine. He is a member of the Task Force Committee constituted by the Government of India to assess, review, and suggest measures of antimicrobial resistance control in India. And he is also on the National Task Force of the Government of India for COVID-19, which is all concerning to us at the present stage. He is involved in the joint monitoring group of the Government of India created for the pandemic and outbreak management in India since 2005. And also, he has actively involved in outbreak monitoring and planning of H5N1, H1N1, MERS, coronavirus, Zika, and Ebola outbreaks in India. Dr. Randeep Guleria is an inspiration to his fellow men and a shining example for everyone to emulate. The Academic Society of JSS Medical College and JS Academy of Higher Education and Research proudly presents His Holiness Jagadguru Dr. Sri Shivarathri Rajendra Mahaswamiji Annual Oration Award to Dr. Randeep Guleria. Congratulations, Dr. Randeep Guleria ji, and thank you for accepting the award that has been bestowed to you in all the good work you have been doing. And I'm sure you will be inspiring many of your medical fraternity who are going to listen to you in achieving and emulating you in many walks of life as you have done. Thank you very much, sir. And we would greatly appreciate if you can put the gold medal on, and please also deliver the oration as requested to you earlier, sir. Thank you very much.
Thank you very much, and I'm really honored to be invited and bestowed with this honor of the His Holiness Shri Jagadguru Dr. Shri Rajendra Swamiji's memorial oration. For me, it's a humbling and truly a great moment, and especially when we are having this on Teachers' Day, and I would like to really at this point in time bow my head to all my teachers, because whatever I am today is because of whatever I've learned from my teachers. And I think for all of us, it's very important not to forget that no matter what be our position. His Holiness Shri Jagadguru Swami Deshikendra Swamiji, Dr. B. Suresh, Dr. K. Satish, Dr. Surendra Singh, Dr. Manjunath, Dr. Baswan Gaudapa, Dr. Kaushalyappa, Colonel Dayanand, other faculty colleagues, teachers, residents, students, ladies and gentlemen. It's truly an honor, and I shall start by delivering my oration. I just want to make sure that my slides are visible.
Yes, sir, it's visible, sir. Thank you.
Thank you. So I would start by really paying my tribute to His Holiness Shri Rajendra Mahaswamiji, the founder of JSS Mahavidyapeeth. And I think what has already been said about this extraordinary Jagadguru is something that we all look up to. The amount of work that he's done is truly enormous, and it has been done tirelessly and with a selfless motive. He established the JSS Mahavidyapeeth in 1954, and that has now grown to more than 300 institutions, and he has established schools, colleges, hostels, and hospitals. And I think what the type of work that he's done during his time has actually become something that has really become sustainable and has benefited millions and millions of people. So I'm really honored that I've been asked to give an oration on His Holiness's name. I shall be talking on issues and challenges in COVID-19 pandemic. I hope my slides are visible, and as I move them, you can see them.
Yes, sir, we can see them.
So what do we know about COVID-19 or SARS-CoV-2, and why is it so dangerous? It's because it has an incubation period which can vary from 5 to 15 days. It has an ability to stay potent on surfaces, especially plastic, steels, and porous surfaces. We are learning more and more about the severity of disease, and we're not sure how much immunity this can give as far as the infection is concerned, and how long we remain protected once one gets infected with COVID-19. Also, we are now realizing that COVID-19 can have an asymptomatic presentation. It can be a pre-symptomatic stage, which can be before you develop symptoms. You can have a mild illness, a moderate illness, but there are some unfortunate people who develop a severe illness leading to severe pneumonia, and then there can be severe complicated illness like ARDS, sepsis, and there are certain presentations which are extrapulmonary, which can be cardiac, neurological, or it can involve various other organs, including the skin and even the gastrointestinal tract. So as this slide tries to show that you have a latent period after which you have an infectious period, but even while you are in the incubation period and in the pre-symptomatic stage, you can still be infectious, as is being shown here. And then, of course, you are symptomatic during the infectious period. And some individuals, although not very large, may continue to be symptomatic even when the symptoms become less or there is resolution of symptoms. If you look at the pathophysiology, this is a virus which actually gains entry into the cell using the ACE2 receptors and the TMPRSS2 receptors also. And it gains entry using the so-called spike protein, which enters, and it can have a direct cytotoxic effect as far as the cells are concerned. But it also causes dysregulation of the reticuloendothelial aldosterone system, and this can lead to inflammation, vasoconstriction, and increased vascular permeability. It also causes what we call endothelial cell damage and thromboinflammation, and this leads to endothelitis or inflammation of the blood vessels, and leads to decreased fibrinolysis and increased thrombin production. We also know that this virus then subsequently can lead to what is known as cytokine release syndrome, and this itself leads to increase in various inflammatory markers like TNF-alpha, IL-6, there's increase in D-dimer, and this leads to a whole cytokine storm which can have fatal consequences. Also, when we first thought of COVID-19, we thought of it as a virus which caused only viral pneumonia and upper respiratory tract symptoms. But now we know that this is a systemic disease. It can cause neurological symptoms, it can cause renal symptoms, it can have hepatic dysfunction, it causes diarrhea, and some patients present only with diarrhea and fever. It causes a hypercoagulable state leading to thromboembolic complications. It can have large number of cardiac complications. Even endocrine complications like hyperglycemia can happen, and it is well known to cause some degree of dermatological complications also. So when we come to the management issues, especially when we're looking at pandemic, the first thing is that since it's a new virus and we don't know what to do about it, we have to rely on what we call non-pharmaceutical interventions. And these non-pharmaceutical interventions help in delaying the outbreak peak, they decompress the peak burden, and therefore this decreases the burden on hospitals and on infrastructure, and it diminishes overall cases and the health impact that it can have. So by doing this, the peak becomes less and the curve tends to flatten, and this gives time for preparation and also decreases the load in hospitals. And this is what happened in India also. We were able to achieve this by having the lockdown, and although the number of cases continue to rise, we haven't had a sharp peak as many countries have had. The intervention strategies that we use are a case of cohort isolation, which has been done aggressively. We have had containment zones and lockdowns, voluntary quarantine, social distancing, which can be school closures and lockdowns, and aggressive hand hygiene, cough etiquettes, and respiratory protection in the form of wearing masks. Currently, what we don't have are the pharmaceutical interventions which are of proven value, and that is basically vaccines and specific antiviral drugs. When we start looking at preventive measures or non-pharmacological measures, the first thing to understand is that how is this virus transmitted? We know that the main route of transmission is droplets and fomites, that is by particles which are more than 5 microns in size and which settle on surfaces. There has been some debate whether they can be aerosol transmission, and this has also been debated, but it doesn't seem to be a major route of transmission. It can be an important route sometimes in an indoor environment. There's also debate about fecal-oral transmission, but this is still not thought to be very significant, or it's highly unlikely. But we do know that this virus can stay in surfaces for a long period of time, and this is possible whether it be copper, cardboard, stainless steel, or plastics. The virus can stay for as long as sometimes 72 to 96 hours on these surfaces and stay viable. So I think this is something important, and that's why hand hygiene and sanitization is an important part as far as prevention is concerned. As I was mentioning, we have droplets which are usually large droplets, and during sneezing, coughing, or exhaling, most of these droplets actually tend to fall to the ground and don't stay suspended for a long. But at times when there is sneezing or coughing, there can be some aerosol generation, and this in an indoor environment may be associated with the spread of the infection. So this is something that we also need to be careful about. The second important thing is, when is the patient infectious? And there have been a lot of modeling studies, and this data suggests that 44% of transmission may occur during the pre-symptomatic stage. That is almost 2 to 3 days before you start developing symptoms, you may have transmission. And it's been calculated the infectiousness starts around 2.3 days prior to symptom onset. And this is what makes this virus more and more dangerous, because you are spreading the disease even before you develop symptoms or know that you have COVID-19 infection. This has also been shown in other cases where it was clearly shown that out of 2,500 secondary contacts of 100 patients, 22 secondary infections, all exposure occurred within 6 days of symptom onset of the index case, and none had actually developed symptoms who were exposed after 7 days. So this is something important to keep in mind when you look at the infectiousness as far as this virus is concerned. Do face masks work? Is physical distancing useful? And this is something which a lot of people have argued, that how effective are these? This is a paper published in Lancet which looked at this in the form of a systemic review and meta-analysis. And this looked at 172 observational studies across 16 countries and looked at more than 25,000 patients and healthcare workers. And the only thing was that many of these, or all of them, were non-randomized controlled trials. But it showed that physical distancing was effective, and transmission of virus was lower with the physical distancing of 1 meter or more compared with the distance of less than 1 meter. It also showed that face masks used could result in large reduction in the risk of infection, And that is why this is something we need to promote more and more aggressively. Greater reduction with N95 or similar respirator was seen as compared to a disposable surgical mask, but the surgical mask or a cloth mask was also found to be effective. It also showed, especially in a healthcare setting, that eye protection was associated with less infection, and therefore in people who are dealing with COVID positive patients, using eye protection in the form of a face shield or goggles is also something which can help as far as this is concerned. So if you're looking at mass reduction to reduce the airborne infection, this classically shows that if both the asymptomatic infected person and the healthy person both wear a mask, the chances of getting infection is minimal as compared to if one of them does not wear a mask, even if the other is wearing a mask. So I think that is why it's important that aggressively promoting wearing masks and physical distancing in the public is needed if you want to bring down the cases in our country. Now, when we come to managing a pandemic, we need to look at triaging these patients. We need to look at where do we manage them, domestic care, critical care, and surge and hospital surge capacity. So whenever there is a pandemic, and this we've noticed in large number of pandemics, including H1N1, there's increased apprehension, there's increased consultation for all respiratory tract infection, which could otherwise have been managed. And sometimes mild cases requiring home isolation also rush to the hospital, and this overwhelms the healthcare system. And therefore, very early what was done was that dedicated facilities was created. We had dedicated hospitals, COVID ICUs, screening areas, and ILI facilities in the form of COVID care centers, and community centers were also created in the form of COVID care centers. It's very important to identify such centers because as the load increases, there is a need to have these centers so as to be able to decrease or distribute the patient load in different areas depending on the severity of illness. What did we do at the All Indian Institute of Medical Sciences? We realized that this was something that we will have to tackle. So early in March, or end of February, beginning of March, we set up a COVID-19 task force. We formed various committees to look into each aspect, whether it was human resources, whether it was how to get our equipment and get the VTMs and the kits for the testing of these patients using RT-PCR. So a regular flow of resources was required. And I started having daily meetings in the morning with the faculty, nurses, the residents to discuss how to manage cases and the problems that we face, whether it was areas of donning, doffing, to measure, suddenly manage a resident's wife who was positive and was at term pregnancy, and to create a labor room overnight, which had all the facilities in terms of protecting our hospital care workers, or to have training for infection control practices. So we looked at various things, developing infrastructure, human resource planning, process redesigning, and of course, other activities like IEC, research, and academics. We quickly converted two of our centers. One was the National Cancer Institute, which is a 700-bedded facility, which was started, and we had just had about 100, 150 beds operational into a into a COVID hospital. And our trauma center also was converted into a COVID hospital. And therefore, we were able to create 1,700 beds for COVID patients and around now more than 200 ICU beds. During the peak, about in June, we had almost 800 to 900 patients admitted in these centers, and there was a worry that this would go up to more than 1,000 or 1,500. This is our new National Cancer Institute. This is a institute in itself. It has a hospital, a huge OPD block, a research block, an auditorium, and residential facilities. And one of the hostels also we converted into a COVID care center. This is a trauma center, which was also converted into a COVID hospital. And we developed a triad system where patients came in who were evaluated, and depending upon whether they were high risk, were then evaluated for the severity of illness and were then kept either in a COVID care center, the ward, or in the ICU. So whenever you have patients in the hospital, you have to take a decision as to the current conditions, complication of COVID-19, worsening of pre-existing medical conditions, other consideration depending on where the patient has come from, whether he has some other problems which needs hospitalization, and various tools can be used to really assess the severity of illness. We also started teleconsultation. We decided that we needed to develop a mechanism where we could consult not only our COVID patients, but non-COVID patients. Until now, we have done more than 134,000 teleconsultations, and we set up the CONTACT, which is the COVID-19 National Teleconsultation Center, which actually handles calls from doctors, public, and patients from all over the country. Again, this is just to give you a breakup till 31st of August of the type of work that we've done in terms of the teleconsultations, the management, both in our cancer hospital, we continue cancer care, and some degree of daycare was also continued, and also dialysis for non-COVID patients was continued. Till now, we've seen close to 6,000 patients who are COVID positive, and this number continues to increase as the number of cases in Delhi are still now again showing a rise. We also started training our individuals, and we trained more than 13,000 AIIMS employees on infection control practices. This was done morning, evening in 2 modules by a hospital infection control team. We also used the online platform that we have for teaching our postgraduate students known as SARL for doctors, interns, and nursing officers as far as hospital infection control training was concerned. We looked at the concerns that the healthcare professionals had in managing COVID, and the main concern was the risk of infection to self and family and disruption of daily activities. And this was actually looked at and addressed by reassurance and appreciation from our senior faculty, connecting them with family and friends, making them feel a pride of their noble profession, and a team-based approach, and also giving them proper duty hours and breaks so that they could recover from this challenges that they had during this pandemic. We also started various national activities. We did the National Excellence Program, the National EICU, capacity building for COVID-19 testing, and the National Clinical Rundowns that we do every Wednesday. We did international training for SAARC countries on various topics, and this was also highly appreciated. And very early, I realized that research has to be done in COVID, and therefore, in March itself, we started our own funding, and we created a corpus of money where we said we will fund our own research projects, and 50 research projects were given intramural funding at that point in time. We have extended that, and now more than 100 projects are being funded by the institute itself on COVID-related research. We've also got research funding from outside as far as ICMR, CSIR, and WHO is concerned. Various portals were started. Education and communication was upgraded. We had this booklet on COVID-19, be careful, not fearful. AIIMS portals were started, videos were uploaded, and we had more than 50 videos. Webinars have been done, and like I said, a helpline was also started. But the challenge that we had was hospital evaluation and treatment. There are various lab features which actually tell us how severe COVID is, and these include D-dimer, CRP, LDH, troponin, ferritin, CPK, and also we look at the absolute lymphocytic count. These are done regularly in moderate to severe illnesses, and we usually do it every 48 to 72 hours and monitor the CBC, the LFT, and KFT on a daily basis. We've had patients who come with x-rays like this, the classical x-ray of a COVID-19 patient, where you see these peripheral multiple ground glass appearances with consolidations, with sparing of the parahyalar area. And we've noticed that you could have 7 different patterns as far as the radiology is concerned. You could have peripheral airspace opacity, which I just showed you. You could have low consolidations, peribronchial consolidations, or you could have multifocal airspace opacities. You can at times have an atypical presentation of almost a mass-like opacity, and then there can be the classical diffuse low consolidation, and some uncommon presentations can happen. So this is the first pattern, which is the classical that we have in a peripheral distributed ground glass opacities, but you can have opacities which may be parahyalar or peribronchial. And then you can have, as I mentioned in pattern 5, a rounded opacity where the star is like almost looking like a mass, which has also been seen at times like in COVID-19. CT has been of great help, and this is now something that we do routinely in our trauma center and in our non-trauma emergency. And we have a dedicated CT in our trauma center for COVID positive patients, and it is shared in the non-trauma ER between COVID and non-COVID patients by sanitizing it in between the scans that we do. This is just to give you an idea. This is a 30-year-old female who presented with fever, cough for 2 weeks, and her initial RT-PCR for COVID was negative. But because of the CT scan and her symptoms, it was felt that she had she probably had COVID infection. This was this rounded consolidation, which is also known as a doll sign, and her repeat test was done, which was positive. Another individual who again RT-PCR was negative, 54-year male with fever and dyspnea. And you can see this patchy ground glass opacities, which are classically seen in COVID-19. Now, we've all learned that these are classical and we can recognize them even when you just look at the first cut of the CT scan. This is another patient who was having persistent fever and shortness of breath. And you see these classical ground glass opacities, which are showing these changes, as some of them also look like as if they have a halo around them. We also started looking at some degree of research, and this is done by one of our faculty members who's also done a training on artificial intelligence as a fellowship in IIT Delhi. And she's used a deep neural network to analyze chest x-rays for diagnosis of COVID. And this was using machine learning based triage of patients to decide who needed hospitalization and who did not, who could be COVID positive and who could be COVID negative. She took more than 700 COVID positive x-rays and also looked at 300 COVID suspect x-rays and took 300 x-rays which were done in 2018, which were in the non-COVID area as controls. And based on that, developed neural network algorithm. So she did training of the algorithm, testing of the algorithm, and subsequently was able to show that this could be used with a high degree of sensitivity and specificity. As a matter of fact, I've seen this, and very often the x-ray to me looked normal, but the neural network actually picked up abnormalities and labeled it as COVID suspect or non-COVID suspect. So X-ray is looking normal, but based on this, the precision was very high. And I think this is a paper which has been sent for publication, but exciting work in terms of how artificial intelligence can still be used in the era of COVID-19 and using a simple chest X-ray to help in diagnosing COVID positivity early on. Coming to treatment strategies, and I think this is where we have a lot of challenges, and the challenges are to treat or not to treat. That remains a question because the data is plus minus as far as most treatment strategies are concerned. The protocols that we use are hydroxychloroquine, azithromycin, doxycycline, ivermectin, steroids, vitamin C, zinc, low molecular heparin, and certain specific therapies in the form of plasma, remdesivir, and an anti-IL-6 drug, tocilizumab. The other important thing that we found is very useful is conscious proning. Now, if you look at the clinical therapeutic staging that has been proposed, it's important to remember that in early stage, that is stage 1, you have a very high viral load, and the viral response phase is the one where you need to look at it from the point of view of treating the viremia or the viral replication which is occurring. But with time, you lead on to what is known as stage 2 or the pulmonary phase. In 2A, the oxygen requirement is not much, but in 2B, there is a higher or increasing oxygen requirement. And this is when the host inflammatory response starts setting in, and we start moving towards a cytokine release syndrome. And this is when your parameters start deteriorating, and you are now thinking of aggressive treatment with steroids, low molecular heparin. And as it progresses, you're looking at other drugs for cytokine storm, because this is the stage where the patient can rapidly deteriorate. So what about antiviral therapies? We all know about remdesivir. It's a repurposed drug. It was actually developed for treatment of Ebola, but then it was shown to have activity against SARS and MERS coronavirus, and some data that it would be useful against SARS-2 also, the COVID-19. And this, as we all know, is a novel nucleotide analog. The paper published in the NEJM, which has been quoted as part of the Act 1 study group, which showed it looked at about more than 1,000 patients and gave remdesivir 200 milligram on day 1, followed by 100 milligram daily for up to 9 days, showed that remdesivir was superior to placebo in shortening the recovery in adults hospitalized for COVID-19. The difference was from 15 days to 11 days, but this did not show a mortality benefit which was statistically significant. There was a tendency towards a mortality benefit, but it did not reach statistical significance. And therefore, although this drug is widely used, we need more data to say that it has mortality benefit. Paper which was published somewhere in the end of August, which again looked at remdesivir versus standard care. This was published in JAMA, which looked at moderate COVID-19. So remember, that previous paper was on relatively severe patients. And this looked at 10-day remdesivir, 5-day remdesivir in standard care. And what they concluded was that among patients with moderate COVID-19, those randomized to a 10-day course of remdesivir did not have a statistically significant difference in clinical status compared with standard care at 11 days after initiation of treatment. But interestingly, patients randomized to a 5-day course of remdesivir had a statistically significant difference in clinical status compared with standard care. And they have concluded that this difference is of uncertain clinical importance. So again, not very sure where remdesivir stands. It does tend to show some benefit, but the data is still equivocal, and we need more data before we say that this can make a dramatic difference as far as managing these patients are concerned. The Ministry of Health and Family Welfare recommends that it can be used for 5 days, only to consider an extension of 10 days if there is no clinical improvement, and taking precautions like looking at the GFR and the liver function test, and currently not recommended in children less than 12 years of age. Here you will have to take a risk-benefit analysis and then take a call on whether you want to give it to children less than 10 years of age. Another drug which is of great controversy, hydroxychloroquine. You all have been using it. I myself have been using it for a long time, more than 20 years. I've used it a lot in sarcoidosis, but it has become, I would say in many ways, to some extent, a political thing. It's whether you're pro-Trump or anti-Trump, but hydroxychloroquine has been shown to have some in vitro activity against SARS-CoV-2. A French study which had methodological concerns also showed that it significantly reduced the viral carriage at day 6. However, subsequent studies, including the recovery trial, the solidarity trial, have failed to show a benefit. The study which was done at the All India Institute of Medical Sciences, and also done another one by ICMR and by certain Delhi hospitals in healthcare workers, did show that those healthcare workers who took a weekly dose of hydroxychloroquine did have lesser chance of developing COVID-19 infection as compared to who did not. And based on this, the National Task Force recommended that we should continue to advise on a weekly dose of hydroxychloroquine 400 milligram to all healthcare workers or those who are coming in close contact with COVID positive patients. There was a lot of concern about QT prolongation, but we've not seen this to be a major cause of concern. And retinopathy was something that we worried about 20 years ago. We used to do regular retina scan in all our patients at that point in time, every 3 months. But now there is enough data that hydroxychloroquine does not cause any retinal changes. It's only chloroquine which has been linked to the retinal toxicity. Lopinavir/ritonavir was a drug which was used a lot in the early part of the pandemic, but now there is enough data to suggest that it probably is not of much use and is currently not recommended. Another drug, favipiravir, which is now available, it is in our country. But again, the data here is not that strong. The paper which is quoted a lot is published in a non-medical journal called Engineering. And this did tend to show that there was some improvement as far as the viral clearance was concerned when favipiravir was used as compared to standard treatment with lopinavir/ritonavir. And we still need to have more data before we say that this drug is actually of much use. It is, the dose is on a higher side, the cost has actually come down, and there are some side effects that we need to monitor this drug for. There has been a study which has looked at triple combination, ribavirin, interferon, and lopinavir/ritonavir as compared to only lopinavir/ritonavir. And this did tend to show that triple drug combination had a more rapid time to clinical improvement and negative PCR as compared to just lopinavir/ritonavir. However, again, more data is needed, and this data is not enough to say one way or the other that this is the standard of treatment. Ivermectin is another popular drug in India. This is based on a study which was done in Bangladesh, which showed that a combination of ivermectin and doxycycline was useful in decreasing the viral load, especially in mild patients, and therefore it has become popular in our country. It is proposed to have nuclear transport inhibitory mechanism, and the dose that one usually gives is one tablet, which is 12 milligrams per day. Some people have also given 2 tablets a day or 2 tablets twice a day also. It's relatively safe and doesn't usually have much side effects. We've been trying to do studies as far as this drug is concerned. The FDA has approved this as far as treatment for COVID-19 is concerned. We've looked at its pharmacokinetics, and this is a pharmacokinetic stimulation study which we've done at AIIMS, looking at different doses and looking at its pharmacokinetics at different doses, because the dose, what the lab data suggests is that a very high dose is needed to prevent viral replication, whereas the clinical data did not suggest that. It suggested that even it was effective at a low dose. We were also doing a study, which is a randomized controlled trial of ivermectin in COVID-19, the REVIT-COVID study, which is, has just been completed. The data is being analyzed. We're looking at one arm as placebo, the one arm is ivermectin 12 milligrams, and one arm of ivermectin 24 milligrams. And we're looking at reduction in viral load and various other clinical parameters. In those who got ivermectin in the randomized group, we found this drug to be safe with very minimal side effects and no serious adverse effects. But the results are still being analyzed as far as its primary outcome and pharmacokinetics are concerned. Coming to convalescent plasma, there were a lot of small studies which came out with 5 to 10 patients in JAMA and in the proceedings of the National Academy of Science, which tended to show that this convalescent plasma may be useful. But what is important is that it should be convalescent plasma, that is, the plasma should be tested for sufficient antibodies in a titer of 1:640, and you must also, if possible, look for neutralizing antibody before you say that this is good convalescent plasma. Some data emerged early which showed that patients who recovered from mild illness did not produce that strong antibodies, and therefore that truly was not convalescent plasma. This is a study which came out in JAMA, about 103 patients which were looked at with convalescent plasma versus standard therapy. And they found that there was significant clinical improvement at day 28 in severe illness, but not in life-threatening illness. So I'm not really sure what we can make out of that. But as far as the primary outcome was concerned, it was not achieved. But the trial was stopped early because of lack of participants, because the pandemic decreased in that area and they were not getting enough patients to give convalescent plasma. But they were able to conclude that plasma therapy was safe. There's a recent publication which is still in preprint. It's still being peer reviewed. And what they found was, interestingly, and this is a study from Erasmus in Holland, where they looked at patients whom they had enrolled. And at the time of inclusion, 53 of the 66 patients tested had anti-SARS-CoV antibodies at baseline. So they found that when they tested the patients before giving them plasma, they already had high titers of antibodies. And that's what caused them to be concerned, that in 44 of the 56 patients tested with median titers comparable to the 115 donors, they found that there was good neutralizing antibodies. And they did not find significant difference in mortality. So they concluded that most COVID-19 patients already have high neutralizing antibody titer at hospital admissions. Screening for antibodies and prioritizing convalescent plasma to risk groups with recent symptom onset will be key to identifying patients that may benefit from convalescent plasma. And that has moved our strategy that we are giving convalescent plasma more at an early stage rather than a late stage, because at the later stage, the patient himself would have produced enough neutralizing antibodies and convalescent plasma may not. The ministry guidelines do recommend that it can be used in patients with moderate to severe disease with increasing oxygen requirement despite use of steroids. And again, they do recommend that neutralizing antibody titers should be evaluated, and one must do the cross-matching and ABO compatibility. We usually give about 200 ml over 2 hours, and sometimes we may repeat it after 24 to 48 hours. What about anti-inflammatory therapies, especially when we are looking at those who have had a cytokine storm? When we talk of cytokine release syndrome, there are a lot of markers which are present, which tell us that this is likely to be there. We have high levels of serum ferritin, D-dimer levels, hepatic dysfunction, thrombotic tendencies, and features of DIC. And all of these actually tell us that this patient is moving more and more towards a cytokine storm. The recovery trial, which is the one which is quoted the most, actually looked at low-cost dexamethasone to reduce death and showed a significant mortality benefit when oral or IV dexamethasone was given 6 milligrams per day for up to 10 days. And this showed that there was a reduced 20-day mortality compared to usual care, which was 22% versus 25%, and this was significant. What they showed was that the benefit occurred predominantly in those patients who were requiring invasive mechanical ventilation or oxygen therapy only. In those who were not requiring oxygen, there was no benefit. As a matter of fact, the dexamethasone arm did worse in terms of mortality as compared to usual care. So this basically means that in those patients who are requiring oxygen and who require mechanical ventilation, there is a role of giving steroids. In the recent issue of JAMA, which has come out on the 2nd of September, there are almost 3 or 4 articles looking at the role of corticosteroids, showing a beneficial effect. And there is one meta-analysis which I'm showing here, which has looked at systemic steroids and mortality among critically ill patients with COVID-19. And it's also looked at dexamethasone, hydrocortisone, and methylprednisolone. Overall, it shows that steroids have a favorable outcome, much more with dexamethasone and methylprednisolone as compared to hydrocortisone. But overall, I think there is not good amount of data which suggests that giving steroids to sick patients actually benefits them, and it's something we must do as standard of care. I remember that when we had the H1N1 pandemic, there was a lot of concern about giving steroids because there was some data at that point in time which suggests a poor outcome in those who were given steroid. There was a study from Hong Kong which suggested a poorer outcome at that point in time. Steroids were not encouraged in these patients. But data for SARS-CoV-19 does suggest that steroids do help. And this has also been recommended by the Ministry of Health and Family Welfare guidelines that a lower dose can be given in patients with moderate disease, and a higher dose of methylprednisolone 1 to 2 milligram per kg or dexamethasone 0.2 to 0.4 milligram per kg may be given for 5 to 7 days, depending upon the severity of illness. Coming to tocilizumab, another very controversial treatment strategy. This is basically an antagonist of IL-6 receptors. So it's a receptor antagonist, and therefore when you give it, the IL-6 levels may go up because you block the receptors and circulating IL-6 levels may rise. This has been used, and there were initial studies which showed benefit. The initial study which came from Italy, which was tocilizumab in patients with severe COVID-19, which was a retrospective study, showed that it had a benefit, and this was used in those patients who were having a saturation of less than 93% and a PaFiO2 ratio of less than 300 on room air, or more than a 30% decrease in the PaFi ratio in the previous 24 hours during hospitalization. And what they showed was that tocilizumab was associated with reduced risk of invasive mechanical ventilation or death, and higher new infections with tocilizumab were reported because this drug does predispose to secondary bacterial and fungal infection. Another study which was subsequently published, which also showed that it had a benefit effect as far as tocilizumab was concerned. The PF ratio improved, although IL-6 was not, as I've already mentioned, a predictor of mortality. More recently, there has been another study which has looked at tocilizumab among patients with COVID-19 in the ICU. And this was a retrospective study of around 630 patients in 13 hospitals. And this looked at around 210 patients that received tocilizumab as compared to 420 who did not. And they also concluded that an association was noticed between receiving tocilizumab and decreased hospital-related mortality. And therefore, this data also suggested that there could be a decreased mortality. This is the data from India by Dr. Atul Patel from Ahmedabad, a retrospective study of about 20 patients. And this data also suggests that as far as CRP and other parameters are concerned, they tend to improve once tocilizumab is given in these patients. However, the study, the COVECTOR trial, which was a phase 3 study, which was sponsored by Roche, the makers of tocilizumab, did not find any improvement, and they said that this did not meet the primary endpoint, and this was not recommended by them as a treatment strategy as far as COVID-19 was concerned. And they concluded that in this randomized placebo-controlled trial in hospitalized COVID-19 pneumonia patients, tocilizumab did not improve clinical status or mortality. And therefore, this threw the whole issue of how useful this drug is into a lot of controversy. More recently, there has been a meta-analysis also looking at tocilizumab, again, not showing much benefit as far as the risk of mortality is concerned between tocilizumab and comparator. ICU admission also did not show that much of a benefit, and also requirement of mechanical ventilation did not really show that much of a benefit. So data remains equivocal in terms of how useful it is. There's been a lot of debate in our task force also as to how useful this drug is. And although we are still recommending it as an off-label indication, I think we need more data. There is varying data. Some data suggests that it's useful. And what I could say as clinicians who've used this drug, that it does make a good difference in some patients. You have patients going into cytokine storm. Giving tocilizumab does help, and you can notice the decrease in a lot of inflammatory markers in the subsequent 24 to 48 hours. But you have to be very careful about secondary infection, and we would cover most of our patients with gram-positive and gram-negative cover, and would closely monitor for fungal infections. And we tend to use a lower dose. The dose varies from 4 to 8 milligram per kg. We would tend to use a dose of somewhere between 5 to 6 milligram per kg. Another drug, tocilizumab, which is also a drug which is available because it is made by an Indian company. It's an humanized anti-CD6 monoclonal antibody, and it's been approved by the DCGI. This is a drug which is actually the data that has emerged is basically from Cuba. This is a drug which has been used a lot in Cuba as far as managing cytokine storm is concerned. We were involved in one of the initial trials in a small number of patients from the safety point of view. Again, one has to be careful because this also leads to a lot of chances of secondary infection in the form of the T cell activity comes down significantly, TNF alpha comes down significantly, and opportunistic infection. And there is some doubt that it may also lead to flare up of a sort of latent tubercular infection. But again, another drug which is cost effective as compared to tocilizumab may also be used in cytokine storm. The role of anticoagulants, again, a very important part as far as treatment strategy is concerned, because SARS-CoV-2 is associated with inflammatory and prothrombotic states. It's been seen that in severe critically ill patients, almost 20% may have thromboembolic disease and 3% may have stroke. And therefore, as part of standard treatment, all hospitalized patients should receive venous thromboprophylaxis. One can debate as to what would be the ideal dose. And also, one observes that biomarkers which towards hypercoagulative state are invariably elevated in these patients. And there are a large number of trials which are currently going on to look at the utility of anticoagulation in COVID-19, not only during hospitalization, but even after discharge. Do these patients need to be put on the novel oral anticoagulants? Does it have any benefit? Number of studies have been done. This is just one study which looked at the role of oral treatment dose anticoagulants in a large number of patients. Almost 760 patients received systemic treatment dose anticoagulants. And this did tend to show that in-hospital mortality came down, was better as compared to the other groups who did not get it. And there was, and especially in patients who required mechanical ventilation. Among those who did not receive treatment dose anticoagulants, there was a lower chance of bleeding as compared to those who received the higher dose. And this data, as you can see, the survival probability was much better in those who required mechanical ventilation. And therefore, this study concluded that systemic treatment dose of anticoagulant is associated with improved outcomes, especially in hospitalized patients. So what is usually recommended is that prophylactic unfractionated or low molecular heparin should be considered in all patients who are hospitalized with moderate to severe COVID-19. And therapeutic dose should be given to all patients with established DVT, pulmonary embolism, or other established thrombosis. We would also give therapeutic dose in all our moderate to severe ill patients because of the concern that there may be microthromboemboli in them, which can lead to fall in oxygen saturation or complications. Effect of proning, I think this is something that we've learned, and conscious proning is something which really helps in improving oxygenation. This is a small study that we did around 45 patients where we, in about 30, we tried prone position and another 15, we did not have prone position, and we looked at various outcomes like intubation rate, the ROX index, and days to recovery. And we found that there was significant improvement. Lesser number of patients who were prone required mechanical ventilation, and this did also suggest a mortality benefit. A systemic review has also been done by our group, which has looked at wake proning positioning. This tends to suggest that the data is still not, it's all over the place, whereas when it looks at proning and requiring intubation and mechanical ventilation, but there is some suggestion that oxygen parameters do tend to improve, whether you're looking at the PF ratio, the PaO2 or the SpO2, it does favor proning, and some patients do really improve dramatically. You have to keep motivating them to stay in the prone position because it's not the normal position patients are comfortable with, and therefore this becomes a challenge in more ICUs. One of the final few points that I would like to talk about, one is predicting infectiousness as far as SARS-CoV infection is concerned. It's an important thing to keep in mind. And if you look at this study of 90 RT-PCR positive samples, only 26 patients had viral growth on culture. And they found no positive culture if the symptoms to test time was more than 8 days, or there was a low cycle threshold, or the high cycle threshold meaning a low viral load. We also looked at various studies and compared the data, and we find that in patients who are RT-PCR positive, after 1 to 2 weeks of symptom resolution, this is more likely to be dead virus shedding, and these patients are not infectious. And this has been reflected in the guidelines now also, which say that asymptomatic patients, those with mild and moderate disease, no RT-PCR test is required before discharge. especially if they are if they've been asymptomatic or it's been 10 days before the diagnosis and there have been no symptoms for at least 3 days, and there have been 10 days in total. So I think it's important to keep this in mind because many patients are just kept in hospital because the RT-PCR tends to be positive and they're just shedding dead viruses and they keep on occupying a hospital bed and sometimes it leads to mental trauma as far as these patients are concerned. So I've not touched upon the vaccine, but this is something I can discuss as if we have. COVID-19 pandemic has thrown new challenges to the health system and to treating physicians. We have to be innovative and develop methods to upscaling our infrastructure and treating multi-system disease that COVID-19 is presenting to us. As more and more healthcare workers are drawn in to treat this disease, training in infection control management becomes very, very important to save lives. We've had to have healthcare workers from ophthalmology, from orthopedics, from basics, we train them properly as far as infection control is concerned. Each area has to develop its own strategy to fight the pandemic using available resources and infrastructure. Early in the pandemic, we had the fear that we would run out of PPEs. We did a research project and we developed a strategy of how to recycle PPEs. And this was published as a plastic use and there could be less requirement of PPEs because at that time it was felt there could be a shortage. So you have to develop your own strategies. Mask, physical distancing and hand washing will help. And I think this is something we need to keep on emphasizing. Steroids and anticoagulants have a role in moderate to severe disease. Antiviral utility is still evolving. I think we still need more data before we say these drugs are useful. And it's unclear how aggressively we need to treat cytokine storm. Do we just need to give steroids? Do we need to give pulse steroids? Or do we need to give other drugs like anti-IL-6 drugs is not still very clear. But I think as the pandemic evolves, we need to develop our own strategies and based on our own experience, develop treatment strategies. We can't keep waiting for the evidence to come because by the time the pandemic will probably have moved on. And as we move ahead, I think it's for all of us, especially those who are involved in policy making, that the lessons learned today should not be forgotten for the future. Thank you very much. And our effort to destroy COVID-19 continues. Thank you.
Thank you. Thank you very much, Randeep. That was an excellent. We wanted to know and we wanted to learn from, the COVID from your experience. There are many questions. I think we have, shortage of time. I'll be very brief. I'll take up only those which were not answered in your talk. For example, you've answered about HCQ, you answered about ivermectin, you answered about favipiravir, convalescent plasma. Those are some questions which were there. I think they have all been answered, very well in your talk. So I won't take up that. Except to ask a question like, for example, who is asymptomatic and has, CT scan showing some, GGO and his oxygen is maintained. Do you think we should go after this patient?
So I think that's something which is coming out because more and more CT scans are being done. But there is data which has emerged which shows that even asymptomatic people, almost 20 to 30% of asymptomatic people may have ground glass opacities on the CT scan for which no treatment is required and it will resolve on its own. So if you have a person who's asymptomatic, maintaining good oxygen saturation, you need to just closely follow him up rather than starting him on antivirals or steroids, because very often these ground glass opacities which you see will resolve on their own without any specific treatment. But they, like you would do for other individuals, they need close monitoring. Now with more CT scans being done, we are picking up a lot of early signs which may have really not much clinical significance.
True. I think the dictum here is don't go after any parameters, go and correlate with clinical parameters. Like we see D-dimer being elevated, the ferritins are very high, but patient is, mildly symptomatic. So you don't go and treat the parameters and you treat the patient as a whole. Yeah, that was excellent. So I'll ask you something about this, therapeutic low dose therapeutic thrombolysis on compassionate grounds. Some have used, and they have been successful in, making these patients definitely better when they used thrombolysis and those kind of, episodes which occur in these patients. you have any experience in your team has any experience regarding this, Randeep?
So we have used it occasionally, and what we do is when we have an individual who continues to have hypoxemia, which is unexplained, that you have a CT scan which doesn't show much changes, but there is sometimes even the CTPA doesn't show much changes or obstruction in the large vessels. But you are worried that there may be microthrombi due to which there is persisting hypoxemia, and saturation is not coming up. He is becoming more and more oxygen dependent. You could consider a limited or low dose thrombolytic therapy as some sort of a compassionate use. There is really not much guidelines for this, and therefore we have done it in a very few number of patients that I can remember. It's not something that we would commonly routinely do. But there are some patients whom you can't explain why the saturation, they need 4 or 5 or 6 liters of oxygen, saturation just hovers around 92. CT looks pretty good. The lung pictures are resolved. There's just a few fibrotic bands, and yet they continue to desaturate. Then when you look at the cardiac parameters are normal, echo is normal, you would think that maybe there is some degree of microthromboemboli, and this may help.
And it may not show up in a CT pulmonary angio.
Sometimes for CT pulmonary angio, unless you do look at the smaller vessels, you may not pick it up because these are microthrombi rather than large thrombus in the main pulmonary vessels.
Yeah. Okay. Also regarding patients who are COVID patients, relatively better compliant lungs compared to non-COVID ARDS, the plateau pressure has not crossed 25 routinely, even with tidal volumes of say 7 ml per kg. So is it necessary to adjust the PEEP in this patient? Should PEEP be about 8 to 10 unless static compliance becomes a major issue? These are some ICU related questions.
So that's a good question, because this is what we've noticed, that and this has been described in the literature, that you can have the patients who have lung involvement can have 2 subsets, that can have 2 types. One is the classical ARDS, but the others are those where the compliance is good, and you can even get away with a larger tidal volume of 8 to 10 ml per kg rather than 5 to 6 ml per kg, and they do well. And they actually need to be given good volume and monitored properly, because they sometimes hyperventilate and develop what is known as self-induced lung injury. So to prevent that, you have to treat it to make sure that they are not causing injury by hyperventilating themselves. Many patients here don't need to be treated as you would treat a classical ARDS patient as per the ARDS network, and you can actually manage with low PEEP and a higher tidal volume.
Okay, yeah, I think that answers why this is different from the non-COVID ARDS patients. What about the role of the therapeutic anticoagulation in all patients? I think you touched upon it. Should we treat them, for example, in an ICU with therapeutic dose, and then those who are in the ward with just a prophylaxis? So what do you think is the guideline, and we should go after it? Even though the questionnaire here says that he hasn't seen many complications of that, but I've had one patient in our hospital who was recovering well and developed a bad intracerebral bleed, and then ultimately we couldn't do anything. So one has to be careful. He was also suspected to be having some small aneurysm. So what do you think is the role for therapeutic anticoagulation in an ICU setup?
So unless it's absolutely contraindicated and you have some indications which may suggest there's a higher chance of a bleed occurring, we would give therapeutic anticoagulation to all patients with COVID-19 who are in the ICU and who are critically ill. In the ward, we would actually start off with prophylactic dose of low molecular heparin. If they go on to a severe illness requiring HFNC or non-invasive ventilation, some of us would actually move on to giving therapeutic dose of low molecular heparin.
Okay. Okay, I think that's all we have. I'll ask you just one rapid questions, just one sentence answer about favipiravir, extensively used in India now. And data, as you said, is not robust, except that one of the trial in India, which is not published yet, the Udvadia's group, said that, it was useful very early. What is your take on that?
So you see, we need more good data. I'm not saying this drug is of no use. It probably could be useful. Favipiravir is again a repurposed drug. It was actually, it's been approved. It was approved in Japan in 2014 for the treatment of swine flu, H1N1. Then there is one trial after that which has looked at favipiravir in Ebola. And it's a randomized controlled trial which showed some benefit. But if you start looking at COVID-19, the data is not that robust, although it's got approved not only in India, it's approved also for use in Russia. And it's mainly for mild illness. And therefore, one can use it. But I don't think that we could say that it's a game changer in terms of making a dramatic difference. Remember, many patients, or a majority of patients with mild illness, will also improve on their own without any treatment, because COVID-19 in asymptomatic or mildly symptomatic disease improves on its own. So whether they improved because of the drug or they improved on their own is something that we need to be very sure of.
Okay. Quick take on remdesivir in those who are not desaturating, but they were hospitalized. As you saw, the US data saying that anybody who's hospitalized, for COVID-19 should receive, remdesivir. Of course, their, patients and admissions is completely different from what we have. So is there any thought on this, on this strategy?
So US has recently now changed its guidelines and said that all hospital patients should be given remdesivir, which was not something that they were doing before, because it was mainly for moderate to severe illness, especially those who had a fall in oxygen saturation or infiltrates in the lung. They have not really shown any data to say why they have changed this. But I think it's more related to the fact that the drug is now more freely available and they feel that it can be given. I don't think we can say one way or the other. But having said that, there are a number of patients who have mild illness, may show some fall in saturation, who do take remdesivir. I've had one patient who's taken remdesivir at home. He didn't get admitted. He just called his GP and got the injection at home. And I was really surprised that he took it at home. But he didn't want to come into hospital. He got a monitor in his house and got the injection taken at home. And he had very mild illness. So there are patients who are taking remdesivir as for mild illness, but we don't have enough data to say that it's going to make a big difference. But absence of data doesn't mean that it doesn't work. It may still be working, but we need to really generate data as we go along treating patients, because like I said, we can't wait for all the data and then say that we should have given it. At the same time, we don't know whether it's working or not. So I think we have to give it to patients who need it, but also keep collecting the data so that at some point in time, we have some evidence one way or the other. That's what I think research in a pandemic is all about.
Yeah. Okay. Thank you so much. I think the last one, from my side and from others is Randeep, RT-PCR negative, maybe 1 time, 2 time, all clinical features of COVID in a pandemic. And there are radiological features, which you showed in one of your case, RT-PCR negative, and then there were classical multifocal, consolidations, ground glass opacity. And then the bioinflammatory markers are also elevated or rising. Do you think we should just treat them like, like COVID and don't face any medical legal issues in this? In Karnataka, we are coming out with a guideline, but many patients and relatives are concerned. Why are, it's RT-PCR negative? Why are you putting us in suspect or in a COVID room? And why are you giving remdesivir? Why are you giving steroids? Is there any thought on this complex issue, Randeep?
So this is a big dilemma that we have at times. And this is related to the fact that you have a clinical radiological picture, which is classic for COVID, but you don't have a confirmatory test in the form of RT-PCR positivity. And then you are in a dilemma as to what to do. I would say that firstly, you should continue to reinvestigate the patient so that if you have a report, you're on solid ground. So even if you have to use proper protection, do a lavage, do a bronchoalveolar lavage and take a sample and get an idea whether this is COVID or not. The dilemma that you mentioned is something which is real. Sometimes you are having a patient who's deteriorating. You want to give steroids, you want to give remdesivir, but you don't have the clinical evidence to show that this is definitely COVID-19. What I would suggest is that you will have to really take the patient and the relatives into confidence, discuss the pros and cons with them, take a proper consent that this is, you're doing this basically because the patient is deteriorating, but the evidence that this is COVID-19 is not there. And this is a question which frequently comes up. We do what we call EICUs every Tuesday and Friday. For all COVID hospitals, we've covered more than 150 hospitals. And I'm just giving you this example because this is a question which comes up, and one person from the Northeast told me about a case that who had a similar history. And he said, I did a lavage thinking that it would be positive for COVID, and it turned out to be Legionella. And the patient responded to treatment for Legionella. So sometimes you have different, so all the shadows that you see on the X-ray may be suggestive of COVID, and you may have a COVID pandemic. But we should not forget that other viral infections and other atypical pneumonias can also present with ground glassing. So that's why I said you must continue to investigate, but also take the patient and the relatives on board in terms of what could be the options.
Okay. Oh, that was excellent. In fact, the radiological features, they mentioned atypical pneumonia, especially those who are CORAD 3 and 4, may suggestive of, I think I've finished all the questions, even though there are questions coming up, but let me not hold you back. And then also there's a function here. And that was excellent to interact with you, Randeep. And it was a great talk. It was a great learning for everyone who attended this webinar on this auspicious day, the Teachers' Day. And we thank all our teachers and who have contributed to our development and what we are, as you rightly said. And I thank the organizers of JSS Medical College and His Holiness Guruji for giving us an opportunity to be here, part of a very important webinar and Teachers' Day celebration. Thanks, Randeep. I think the organizers will also say a few words. Thank you.
May I now request other chairperson, Dr. B. Suresh, to also give his chairperson reflection. Before that, I have just 2 questions. There are 24 questions which are just lined up, and 23 chart comments are also there. Many of them have been answered already. And 2 important things: thromboprophylaxis on discharge of a patient who has received therapeutic dose of a moderate to severe patient who recovers with discharge. Do we recommend oral anticoagulation? The first question. Second, the line of questions are related to vaccine. We seek comments from Randeep and Randeepji, and then we have reflection from our Pro-Chancellor.
Okay, thank you very much. The first question is whether we should give oral anticoagulants on discharge. Now, this is something which certain hospitals in the US are doing. What we suggest is that routinely we should not give oral anticoagulants on discharge to all patients. However, at the time of discharge, you may take a risk-benefit analysis. If the person has features which may predispose him to a thromboembolic event in the form of being bedridden, obese, or moribund, you could consider giving oral anticoagulants. Some people also look at the D-dimer level at discharge, and if the D-dimer is markedly elevated, would give oral anticoagulants for 4 to 6 weeks. So this can be done on a case-to-case basis. Regarding the vaccine, we have now 3 vaccine trials which are going on in India. The Bharat Biotech, the Zydus, and the Serum Institute vaccine. They are now, 2 of them are actually in phase 2. And the Serum Institute, the Oxford vaccine is in phase 3. There is also talks with the Russian government to try and see whether we can do a trial in the Russian vaccine. The recent paper in Lancet, where the sample size was very small, did show that this vaccine also was safe and did produce some degree of immunogenicity, but we need more data. Also, I think it's important to remember that no matter where the vaccine comes from, bulk of it will get produced in India. India produces 60% of all the vaccines which are marketed globally. And we have a huge market potential and therefore manufacturing potential. And therefore, this is something that we're looking at. Already many companies with support from the government are looking at upscaling their manufacturing plants. And this is not only production of the vaccine, but production of vials, production of caps, production or mechanism of transporting the vaccine, using the cold chain mechanism. And all of that is being actually worked right now so that once the vaccine is ready, all of this is also there in place so that it can quickly be rolled out and given to people who need it. There's also discussion going on as to how to prioritize the vaccine. Who gets it first? We will have limited doses. We will not be able to do universal vaccination in the beginning. So that also is going on. And there is also this whole issue that we need to look at vaccine for everyone globally. There should be no vaccine nationalism. That is already happening in some countries, that they feel that if vaccine is made in our country, it should be only for our citizens. So that is also a move, that there should be a vaccine which is universal. This is something that has been also addressed by our Prime Minister, that we are one humanity, we are one race, and we should have a vaccine for everyone, rather than just saying that this is for Indians or for Americans or for people from Europe. It should be for everyone who needs it. So I think a lot of effort is being done for vaccination. Thank you.
Thank you, Dr. Randeep Guleria. It was an excellent talk. I think many of the audience who have been viewing have been calling it excellent discourse for them. And they are asking whether they can have these slides. But I would like to tell the audience who wanted those slides that, see, just seeing slides without the talk behind it makes no sense, particularly if you are not a professional who is familiar with the outcomes that are mentioned. But this whole talk would be available on our university website as well as on the YouTube. So you can go and see there, the slides would be there, the talk would be there. And to some more questions and chats that have come out, I would not do it, but I would like to reassure the audience who had put those questions that we'll send these questions across to Dr. Guleria, and in his busy schedule, we'll at least get a one-line reply from him and again host it on our website. So it will give you the answers which you are looking for. Thank you again, Dr. Guleria. I think it was an amazing talk, and you have covered everything, right from the defining it that it is no longer just a pulmonary related viral infection, it's now a systemic infection. So you have to consider that it can affect any part of the body, and we have to be prepared for those such eventualities as it comes in. You discuss about the intervention strategies. You talked about pharmaceutical interventions, what is doable, what is not doable, what is advisable, and what is non-advisable. I think it cannot be more explicit than this for any health professional who is handling COVID care patients and trying to do. You also spoke about the strategizing about the preparation that has to go into in any organizational system, particularly in such type of situation. You spoke very well how you have been addressing this at not only at your institution level, but at the national level. And it is because of these efforts of strategies that today India, in spite of having 1.2 billion population, and with such type of movement of people taking place, in spite of the advisories given, is still under some sort of control and some semblance where we are able to provide care, is all because of the excellent strategizing done by the government, by the professionals like you sitting at Delhi and preparing all these guidelines for the institutions to follow. And you touched about the research, what is happening there. And that gave a very clear insight that research is a continuous process. You cannot decide that, yes, we have reached the end point. Maybe people keep talking that, okay, once you have the vaccine, you may have an end point to this whole matter. But I am not sure that that is going to be so. Vaccine will help, but the end point would come only when we really understand how the virus behaves and why it behaves so, and how we can curb it at the stage where we can control it right in the beginning without coming into us. So, and for that you gave excellent way. Right now, you don't need anything else except to maintain the triage which the government has been keeping on telling, maintain social distancing, have a facial cover, and try to have all those good practices that can prevent you from getting infected. That is the best strategy to maintain the health and do it. You did very well, and really you touched very clearly on one very, very important fact which is dear to me also, and that is the artificial intelligence in the health. I think this is a tool which is going to change the clinical approach which all the medical fraternity is going to give, because this is something you can always validate yourself before you move forward, or even if it is you are moving forward, it is something to fall back and check. Let me check and see. And I think more and more such initiatives in the artificial intelligence are required to be focused. And I am sure these type of efforts will now, artificial intelligence in healthcare would integrate and move forward. And you also touched upon the predicting of infectiousness. And I think almost you have covered from end to end, and I don't think there can be a better treatise on the COVID-19 pandemic and the care that has to go with that. Thank you very much for that. In this, I think it's a befitting oration. And this particular moment when the nation is looking for support coming in from the professionals like you, and also particularly the Rajendra Swamiji, who always said patient is somebody very dear for you and you have to work continuously for him. And on his oration and his 105th Jayanti celebration, there cannot be a befitting talk. Thank you very much, Dr. Guleria, and JSS Academy of Higher Education and Research, the Medical College, and all our faculty and staff are indeed thankful to you for this, and we wish you all the very best. Eminent scientist in you, eminent clinician in you is definitely going to bring many more new things to our country, and wish you all the very, very best. And His Holiness Swamiji also has conveyed his blessings and best wishes to you in all your endeavors. Thank you very much, sir.
I thank both the chairpersons for excellently conducting this beautifully delivered oration. Now I request the orator, Dr. Randeep Guleria, to show the medal to the audience. Thank you so much, sir.
Thank you.
We are really privileged to have your oration on this occasion, and we are extremely happy that you have done it wonderfully well. And I am assuring all the participants and others that this has been video recorded and it will be made available on our YouTube, and everybody can watch it. And all those who could not log in can also see it. And I seek permission from Randeep ji for doing that.
Yes, please. Thank you.
Thank you so much, sir. And I hand over to mic to our Academic Society Secretary.
Seeking the blessings of His Holiness Jagadguru Dr. Sri Shivarathri Rajendra Mahaswamiji, and my sincere pranams to His Holiness Jagadguru Sri Shivarathri Rajendra Mahaswamiji. We now move on to the Teachers' Day celebration. May I request our Honorable Vice Chancellor Dr. Surinder Singh to share his thoughts about the significance of Teachers' Day.
I am thankful to our Vice Chancellor, Dr. Surinder Singh, who is the one who connected me with Randeep Guleria, and he made a pivotal role in getting our Randeep Guleria on board for this oration.
Thank you very much, sir. Invoking the blessings of His Holiness Jagadguru Dr. Shri Shivarathri Rajendra Mahaswamiji, and submitting my respectful and humble pranam to the lotus feet of His Holiness Jagadguru Shri Shivarathri Kendra Mahaswamiji, the Honorable Chancellor of JSS Academy of Higher Education and Research.
Just call me in 10 minutes. I am in a
meeting. And also greetings
today
in this evening to our honorable guest and the speaker, Dr. Randeep Guleria ji. I would like to, sir, express my profound gratitude on behalf of entire JSS Academy of Higher Education and Research for having acceded to her request. And we all feel honored by your presence over here and having graced this occasion. Thank you very much, sir. I also extend my greetings to Dr. K. Satish, President, Karnataka Pulmonology Association, our other dignitaries, Dr. C.G. Betusmarji, Dr. B. Suresh ji, Dr. Basavana Godappa ji, Dr. Colonel Dayanand, Dr. Kushalappa, Dr. Manjunath, Dr. Satish Chandra ji, all the dignitaries, teachers, and the faculty who are on board, and the guests who are on this momentous occasion present over here. Today, it's a great honor for all of us to have Dr. Randeep Guleria ji amongst us on this Teachers' Day. And as he rightly said, whatever we are and whatever the way we have been shaped and molded and the positions which we occupy in our life today, I think we all owe it to our teachers. And this day is being celebrated in commemoration of Dr. Sarvepalli Radhakrishnan ji, who was the first Vice President and second President of India, and more importantly, an educator at heart. GSS Academy of Higher Education and Research and the GSS Mahavidyapith have since the beginning laid a lot of emphasis on teaching learning environment and the teacher quality. This is also reflective in the various rankings and accreditation results, wherein our philosophy and the process of teaching, learning, and aspiring young students has been recognized and rated highly amongst our peers. The impact of training our students and making them successful healthcare leaders was very much visible during the current testing times of COVID-19 pandemic, which was witnessed to our alumni contributing significantly and being recognized as leaders and frontline warriors within the country and overseas. This impact has been possible because they were motivated, trained, and educated in our constituent colleges and institutions, which believe in a strong and robust educational system with a well-defined graduate attributes. And I think we owe it all to His Holiness Jagadguru, Dr. Shri Shivarathri Rajendra Mahaswamiji, who laid the foundation for it. And this legacy is being carried out by our Honorable Chancellor forward. The recent pandemic also witnessed a redefined role of teachers, and teachers across the world have adopted to the change in the educational system being delivered through online mode. And at our GSS Academy of Higher Education and Research, we can very proudly say that our faculty, who was not very well conversant with this online mode, were very quick to adopt to it, and all our students have been able to complete all their studies, their courses, their semesters, everything on time. And we feel very proud of it. The technology has reinforced the role of teacher, and fact that the technology can only be a powerful tool which the teacher can utilize to enhance the learning, but it can never replace the teacher. This has also highlighted an important attribute of a teacher, which is to adopt to change, and we are proud of our teachers who within a short span of a time adapted and equipped themselves to continue the academic activities without any disruption. I think they all deserve a lot of accolade and appreciation of all of us. To recognize the eminent teachers who have contributed to the cause of motivating and inspiring young healthcare graduates, the GSS Academy of Higher Education and Research has a continuous and inbuilt mechanism to identify and appreciate the good work being carried out by our teachers. On this occasion, we have identified faculty from the constituent colleges who have beyond expectations provided guidance and motivation to our students and have gone beyond their line of duty. I congratulate all the faculty members being recognized on this day and wish everyone a very happy Teachers' Day. Thank you and wish you all the best. Thank you.
May I now request Dr. Kushalappa, Director Academics, to coordinate the Teachers' Day program. Dr. Surinder Singh, Vice Chancellor, and Dr. Manjunatha will be felicitating the teachers. The teachers whose names are being called upon may please come onto the podium and receive their felicitations.
Seeking the blessings of His Holiness Rajendra Mahaswamiji and seeking the continued blessings of His Holiness Sri Deshikendra Mahaswamiji, I bow and my obeisance and pranams at your lotus feet. First of all, I thank the organizers for having given me this privilege to introduce my colleagues. I can talk to all of them as my colleagues because I am part of the university now. And all 6 of them are important for us. So I do not have any yardstick to see who I will call first. So that was a dilemma. But then I thought I should
use some yardstick, and the yardstick I used was the year at which.
नहीं मैं बताता हूँ, मैंने कल बोला था उनको, उन्होंने बोला कि मैं तो सिर्फ वीडियो कॉन्फ्रेंस
I had taken the year of joining as a yardstick to call them, and in that order. So first of all, I'd like to call the person who joined Jesus Medical College in 1985, literally opening the doors of the Department of Anatomy, one of the faculty who has made the anatomy department of JSS Medical College known internationally through his work in plastination. He has 14 publications and more than 75 awards and felicitations, both nationally and internationally. Innovation runs in a system. Give him any discarded item and he makes something out of it. I present to you Dr. Chancellor MN, Professor, Department of Anatomy, JSS Medical College, and I request our Honorable Vice Chancellor and Registrar to felicitate him. He's practiced interdisciplinary teaching long before it was thought of, and a man who made the study of anatomy an interesting subject. Dr. Shyam Sundar, MN. Next, thank you, sirs. Thank you, Shyam, and wish you all success. Next, we have Dr. Doreswamy B. He is from the JSS College of Pharmacy, Ooty. So he is not here with us, but I would like to say a brief for this thing. He's a professor and head Department of Pharmacognosy, JSS College of Pharmacy, Ooty. He joined the institution in 1988, and he's one of the lucky faculty to have grown under the legend Dr. B. Suresh. He has over 100 publications, authored book chapters, and has done extensive work on identification of medicinal plants in the Nilgiris, bringing out a compendium, helping to bring out a compendium on the same. And he has also guided 9 PhD scholars and many postgraduates, and also has some projects to his name. Dr. Doreswamy, if you are listening to us, congratulations to you, and the certificate will reach you. Congratulations, Dr. Doreswamy. I next call upon the person who has joined the institution in 1989 and is presently an assistant professor in the Department of Pharmacy Practice in JSS College of Pharmacy, Mysore. He has authored 2 book chapters and is authoring 1 more, Application of Statistics in Epidemiological Study. He is the man, Mr. Panchaksharappa Gowda, DH. This is the man every research scholar turns to for help, especially in statistics. Congratulations, Dodre. Thank you, sir. Now I call upon the person who is a role model to anyone wanting to do research. He has motivated many of the dental faculty to do research. He has over 80 publications and authored 2 chapters in books and 5 monologues, has close to 20 awards and projects to his name, and the latest one being the Innovative UV Dental Chair. Dr. Nandalal B., Professor and Head, Department of Pedodontics and Preventive Dentistry. JSS Dental College and Hospital, Mysore, is our man at many professional bodies where he has been in top positions, and Mr. Research at the JSS Dental College. Congratulations, Nandu. Thank you, sir. I now call upon the person who joined the institution in 1992, quietly efficient, and who has brought the Department of Pharmacology to the forefront with his research and publications totaling over 40 and 2 book chapters. Dr. R.N. Suresha, Professor, Department of Pharmacology, JSS Medical College, Mysore. He has won a national award, Bharatya Chikitsa Ratan, and many other awards for outstanding contribution. He has done extensive work in pharmacological management of diabetes, where he has undergone expert training and acquired a PG diploma. It must be mentioned here that he is instrumental in the meticulous management of the Institutional Ethics Committee and has also obtained the NABH accreditation for the IAC. Congratulations, Doctor, and thank you, sir. Last but definitely not the least, I call upon the man who joined the institution in 2016, although his reputation as a teacher par excellence had preceded him long before. His stint in the Army Medical Corps has inculcated the discipline in his teaching and work. His work experience and teaching for over 30 years has groomed many anesthetists. Dr. Gurudat CL, Professor and Head, Department of Anesthesiology, JSS Medical College, Mysore, arguably the favorite of the postgraduates because of his teaching skills. Has over 15 publications and has widely attended conferences, has also undergone special training programs. He is a trainer and assessor for the DND program also, a quiet and efficient worker who has literally electrified the department. Congratulations, sir. And thank you, sirs, for the fellowship. Thank you very much, sir, and thank you for the honor, sir.
Thank you, sir. May I now request our Academic Society Chairman, Dr. Chancellor, to deliver the vote of thanks, which will be followed by the recitation of the national anthem.
So, offering my pranams to His Holiness Jagadguru Sri Shivarathri Rajendra Mahaswamiji and seeking the blessings of His Holiness Jagadguru Sri Shivarathri Rajendra Mahaswamiji. Good evening and wish you all happy Teachers' Day. Today we had Padma Shri Dr. Randeep Guleria, Director, All India Institute of Medical Sciences, New Delhi, who delivered this year's prestigious His Holiness Jagadguru Dr. Sri Shivarathri Rajendra Mahaswamiji annual oration, in spite of his busy schedule during this pandemic situation. On behalf of the Academic Society of JSS Medical College and JSS Academy of Higher Education and Research, I profusely thank Dr. Randeep Guleria. I thank our mentor, Dr. B. Suresh, Pro-Chancellor, JSS, AHER, and Dr. K. Satish, a renowned pulmonologist and President of the Karnataka Pulmonology Association, for chairing this session and for their reflections on the oration. I offer my heartfelt thanks to Dr. C.J. Betsurmat, Sri S.P. Manjunath, Secretary, JSS MEP, Dr. Surinder Singh, Vice Chancellor, JSS AHER, and Dr. B. Manjunath, Registrar, JSS AHER, for their gracious presence and felicitating the teachers on this Teachers' Day occasion. I thank Dr. P. A. Kushalappa, Director of Academics, JSS AHER, for coordinating the Teachers' Day celebration. I congratulate all the teachers who have been honored on this day, and I thank them for accepting the felicitation. I thank Dr. Dayananda, Colonel Dayananda, Director, JSS Hospital, and Dr. M. Guruswamy, Medical Superintendent, JSS Hospital, for their help and support. I profusely thank our beloved Principal, Dr. Basavanagoudappa, who is a constant source of inspiration to all of us. I thank our Vice Principals, Dr. G.V. Manjunath, Dr. M.N. Suma, heads of the department, teaching faculty, non-teaching staff, and my dear students for being part of this oration. I would like to thank our Academic Society office bearers, a dynamic Dr. Subramanian R., our Secretary, Dr. P. Ashok, and Dr. Vijaya Wagish, Joint Secretaries, for all their dedication and help. I thank the IT team of JSS, AHER, and JSS Hospital, headed by Mr. Ravindran and Mr. Sadanand respectively for their help in successful conduction of this event. Before I conclude, I thank Mr. Rajesh, who is in charge of this beautiful auditorium, for all his help in making arrangements in this event. So thank you one and all.
We shall now rise for the national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Happy Teachers' Day to all. We can proceed for refreshments.